right, greetings 5070 crew. I am Dr. Kate Myers-Coffman, and I've created a short video to complement what you've learned in your module on PTSD in relation to how PTSD can often be misdiagnosed. And misdiagnoses can happen at any point in time because there's lots of overlapping and common symptoms across a variety of diagnoses. Yet underlying and unresolved trauma can manifest as PTSD, but be inaccurately presented as another diagnosis. And that could be something that you come up against. Obviously, you know that we as music therapists, unless you have training in another discipline, do not diagnose, but our awareness of diagnoses and underlying roots are really beneficial. So we're going to talk about what some common diagnoses are, the impact and how, the impact of these misdiagnoses, how these misdiagnoses occur, what are risks if we kind of take diagnoses at face value, and then what can help in our practice. So this is kind of a busier slide. So I'm going to start from like left side to the right side. So common misdiagnoses in children in relation to PTSD, it can often be diagnosed as ADHD, attention deficit hyperactivity disorder, oppositional defiant disorder, and mood and anxiety disorders. So you see an infographic on the right side that is a presentation from somebody who has a website called Neurodivergent Insights. And it's somebody who focuses a lot on neurodivergence and misdiagnoses within that. So you can see the different elements, the common symptoms, common things that present, and how there's so many in this middle Venn diagram that are shared. And so if you don't have kind of an exhaustive, thorough understanding, what can be the risk, So when we think about working with somebody and maybe we're told that they are diagnosed with ADHD, some things that can be present could be, this impulse control challenges, irritability, restlessness, distractibility, this forgetfulness, concentration and attention span issues, and challenges with emotional regulation. So, if you're working with somebody who has an ADHD diagnosis, maybe they're on medication for it. Because medications for ADHD are stimulant based, a child who may have trauma where their responses are actually more traumatic stress related, this is going to be challenging because if they're on medications that are stimulants, they're going to be even more anxious and hypervigilant because the medicine isn't actually doing what they're supposed to be doing. So you may be given a referral and say, hey, this is somebody with ADHD and they have irritability and restlessness. They're really anxious. They have a hard time regulating their body. And so you're going in thinking, how am I going to help, use music in a way that's going to address, maybe this anxiousness, maybe a hypervigilance or something like that. And you can't actually fully address it because physiologically what's happening in their body is that the medicine is hindering more than it's helping, because maybe it's trauma related and PTSD focused as opposed to ADHD focused. And so you might come up against not being able to help somebody in a certain way because you're getting this referral, you're getting this idea, and it's being conceptualized under ADHD, but your ability to teach emotional regulation through music therapy is constantly going to be combated because somebody is maybe being prescribed medication. And so, they don't understand body responses. They don't know how to work with their emotional and sensorial regulation because it's just kind of out of whack. Whereas if you were working with somebody who is accurately diagnosed with PTSD and not ADHD, you might understand how trauma has impacted the nervous system and the neurological system, and you can engage in music therapy experiences to work on grounding, sensory tolerance, emotional tolerance and regulation, mindfulness kind of experiences. And that's going to look very different in an outcome than if you're working with somebody who is diagnosed with ADHD inaccurately. Similarly, if you get a referral or you end up working with somebody who has been diagnosed with oppositional defiant disorder, maybe that child is viewed as aggressive or, whatever that's presented as and coded for, lots of different instances. And maybe they experience temper tantrums a lot, or they just have a higher baseline of being angry or irritable. This could potentially be diagnosed as ODD without a thorough sociohistorical understanding of that individual. And so what people may do within oppositional defiant disorders try to work on anger management and expressing feelings in healthy ways. And so maybe you get a referral for that. But perhaps the real issue is somebody experienced chronic trauma and has a core internalized belief that they're unsafe, that people are going to hurt them, that they don't trust other people. And so they're interpreting people's interactions as hostile, as their fight or flight mode is being kicked on and they are ready to fight. They are ready to protect themselves. It's a coping mechanism rooted in trauma. And so if you are only looking at it from ODD, you risk kind of assuming that you can navigate, like you're just kind of putting a Band-Aid on things, because if these outbursts, if the aggressiveness, if the tantrum is a coping mechanistic response to something that happened that is so deeply rooted, you're just going to teach how can you manage your emotions, but not how can you get to the core root of the issue. That once you get to the core root of that issue, which may be trauma related, you're going to unfold things that allow for those potentials for emotional regulation to happen. So your music therapy experiences would look quite different. With ODD, you might be trying to just work on emotional regulation here and now, what's happening here, what's happening now. If you're working with somebody who has an accurate diagnosis of PTSD, you might be trying to create music therapy experiences that explore and rebuild trusting relationships, positive experiences, hopefully rewire that core belief into something more hopeful. And so it's just going to shift the way that you practice things. And if you're only going in with this diagnosis and you're not really thinking about what these other potential circumstances or explanations could be, that's going to just make your whole practice look completely different. So in adults, a common misdiagnosis is borderline personality disorder, bipolar disorder, motor anxiety disorders. And there's actually a lot of discussions happening right now about complex PTSD, which is where traumatic events have repeated over a period of time. And it's not just maybe like one traumatic event where PTSD might be diagnosed. So there's a lot more happening that seems to be shifting, and it's not formalized in the DSM quite yet, but at least as of this recording, in 2022, December. But there's a lot happening in having borderline personality disorder be kind of umbrellaed under chronic or complex PTSD as a better conceptualization of what's happening. But here's some of the nuances or what this might look like for you if you're working with somebody who is diagnosed with BPD when they maybe ought to have a PTSD diagnosis or vice versa. So for example, mood swings, changes in mood you can see in this Venn diagram is kind of something that's across both diagnoses. And obviously trauma can impact changes in mood and emotional regulation. Again, going back, it impacts neurological nervous systems, everything. So if we're working with somebody who has PTSD or CPTSD, the mood swings could manifest as like, say, a panic attack. Something where if you could teach music-based strategies for being in the here and now, being aware of sound, being present, being mindful, kind of gathering evidence that helps you understand that you're not in danger, that you can think about using music or humming or something that can be kind of physiologically and emotionally grounding for somebody, that's going to be possible with somebody who has a PTSD diagnosis. But if somebody has a borderline personality diagnosis, that's going to look different. It just, the approach is going to be different, because trying to teach strategies isn't going to be as helpful. It's actually going to be more of a hindrance and could exacerbate things, because for borderline personality disorder, feeling affirmed, feeling heard, feeling validated, that's going to go, having that empathic understanding, that's going to go further than here's these strategies. And so if you're working with somebody with BPD, you may approach emotional regulation musically through attachment and co-regulation in music. And you might not even consider teaching music-based strategies for certain stabilization of mood swings, because you don't think that potential is there. But you could be missing out on potential psychoeducational efforts to teach music-based, mood management, if a diagnosis isn't accurate. So, there are these commonalities, but some of the frames of how we work are going to be greatly shifted based on what we're doing. So how do misdiagnoses happen? Research has shown that there's, with so many overlapping symptoms, there's a lot of confusion on differential diagnoses, and as well, there's comorbidities, so multiple diagnoses happening at the same time. It's not a simple, come into the office, we'll ask you some questions and we'll figure it out right here and now. Diagnosing often takes time. It can be formal screening, lots of interviewing, getting a really deep and thorough background on somebody. And so obviously this kind of builds into the next point. If you have a lack of experience, obviously not you as music therapist, since it's outside of your scope of practice, but if the person diagnosing doesn't have a lot of experience, that's going to impact that. And we can relate to this because we understand, we can empathize with this idea that the more experience you have, the more awareness you have, the more clinical encounters that you have, the more diverse circumstances and situations we witnessed and worked within, the more nuanced ways symptoms, behaviors, moods, and actions present and manifest. We have more information to draw on to inform our practice. That's just like a general across the board thing. And so somebody who doesn't have that, who's maybe in an early profession, may be diagnosing somebody, but the weight of that has lots of repercussions. And then if somebody doesn't take the time to go deep into a diagnosis and a thorough screening, and a thorough assessment, a thorough intake, you're going to miss some things. And so then you're going to say, oh, this is explained by X, Y, and Z instead of ABC. And then the whole course of treatment gets impacted. So that leads us into the impact of a misdiagnosis. And it can be pretty severe, For one, an incorrect treatment can re-traumatize if you're not fully aware of what somebody should be getting in terms of a treatment or a therapy. And if you couple this with, because they're having one diagnosis and it should be something else, then they're getting a lack of access to the appropriate treatment that they should have. And that could mean an inaccurate or an unnecessary medication, like the example I gave with ADHD, and that can leave lasting physiological, psychological, and somatic effects. If somebody's been taking medication for an inaccurate diagnosis for years, their ability to understand and know their body is greatly hindered, to know their brain and how it works is greatly hindered. It impacts their self-awareness, their sense of self-insight, and that's going to be aware, be present for you when you're working with somebody to say, okay, there's a disconnect happening. What is this disconnect? And, somebody's self-concept and identity related to a diagnosis and whatever stigmas, are perceived or how they understand them to be, can be greatly impacted. So diagnosis, somebody can feel really comforted once they receive a diagnosis. They can be like, what is wrong with me? Oh, this is wrong with me. Even if most people don't want to think about a diagnosis as wrong, I have heard those things come out of people's mouth. It's like, why am I like this? Why am I this way? Oh, this makes sense. I understand this because I have this diagnosis. For some people, a diagnosis can be further stigmatizing for their culture, for their family, for their community, for their own understanding of self. For some people, it can take years for them to come to terms with the diagnosis or root themselves firmly in an identity based on their diagnosis. And so if that's inaccurate or that changes, that's a lot to take in emotionally and psychologically and even physiologically if the treatment they've been receiving relates to medication. So for us, what are the possible risks if we assume diagnosis is totally accurate? We take everything at, total face value. We might overlook unprocessed trauma or not recognize trauma as the real root of an issue. We potentially reinforce or enable maladaptive or unhealthy coping mechanisms. We might misinterpret behavior because we're not recognizing the real root of an issue. And we could re-traumatize because of that. We may not realize that what we're having somebody experience in music experiences could be something that, because an underlying trauma was never addressed, never processed, never healed, that we're reopening opportunities for that person to experience this trauma in different ways. It's not like re-traumatization always happens in like an abuse, or there's so many types of traumas and ways that we understand and act behaviors and actions and moods related to traumas that if we're just unaware, we could do some harm, and it's, which also leads me into the next slide of what can we do to help. First and foremost, get some trauma training. Doesn't have to be like, here's a trauma specific practice, but look at trauma informed practice from a general framework. Some of you taking this may have taken my trauma course already, and your lens may have shifted for how you look at music therapy practice. And if you haven't taken that yet, I encourage you to do so, or find a trauma training external from Malloy. There's so much around. So it can just be a really helpful guiding work. So remaining curious and not assuming. Don't just assume, oh, this person has X, Y, and Z diagnosis, I know what I'm entering into here. That bears no relevance. We have to remain curious. We have to understand that things will be unearthed. We have to stay humble. And, speaking about humble, practicing cultural humility. A lot of diagnoses are impacted by cultural stigmas or beliefs about cultural traits, personality characteristics. There's a lot that, the DSM in particular has roots in ableism and racism that, need to be teased out and understood. And so what might be presenting for one person may have a wholly different experience and explanation than for another person. So being reflexive and critically minded can be helpful for that. Seeking supervision from professionals that are more experienced than you can be so very helpful in parsing out challenges, curiosities, countertransferences, things that can show up. Even peer supervision, if because supervision can sometimes be financially inaccessible for people. So peer supervision is also a really great option, because each person brings to a peer supervision group different lived experiences that can inform the clinical and professional perspectives. If you're working in a setting where you can dialogue with an interdisciplinary team, if a diagnosis is in question, that can be really helpful, because you can, while we're not equipped to diagnose, we can talk with people who do have that training and background. And maybe you can bring up something and shed light on something that's coming up in your sessions that could reframe, reorient, or clarify something that might be relevant within a diagnostic understanding for somebody. And so you sharing that and dialoguing interdisciplinarily can be really helpful. Building a referral network of trauma-informed care providers and support organizations. This is really important, and it's essential, because you're not going to be the be-all person for every person that you work with. There's something that's going to come up that's outside of your scope of practice, outside of your level of training, your level of education, and building a network so that you can say, oh, here, I'm going to connect you with, these people or this organization, or, send you here. That's going to serve the people that you're going to work with. And as always, bring that humanistic element. So support what people bring in any given moment, because we don't want to come from a place that's always bringing in preconceived notions of how to work with folks. Diagnoses are helpful in many ways, but they're one piece of a picture, and they might not be the most accurate, obviously, from this presentation. And so we really just have to take everything with a grain of salt and really just work with who is in front of us and what they're presenting to us. So I'm hoping that, my goal for this presentation wasn't to just be like crash down the whole system, because diagnostic is, there's pros and cons for everything. There's really good things that come, from diagnoses offering the ability to access treatments. But we also can have an awareness of where might something fall short. And if pieces aren't coming together, how can you help be somebody that can build those pieces together and work with somebody in the moment where they're at, bringing your knowledge base into that. So showing the references for the sake of showing the references, but I will make sure that everybody has access to these slides, just so you can, have these resources and references that you can have this to refer to. But I hope that this is a helpful addition to the module. Thanks, everyone.